Welcome to this deep dive into the source material. We have pulled together, well, a rather intimidating stack of sources today.
We absolutely have, yes.
Right. We are looking at the American Gastroenterological Association's clinical practice updates on refractory celiac disease.
And the joint UEG and ESPEN consensus guidelines on intestinal failure, alongside a pretty formidable collection of oncologic surgical data, specifically regarding enteropathy-associated T-cell lymphoma.
Exactly. Our mission for this deep dive is to exhaustively evaluate malabsorption syndromes and intestinal failure. But we are doing so strictly from a rigorous Level 7 surgical perspective.
Right, no superficial dietary advice here. We are plunging directly into the molecular pathophysiology, the diagnostic hierarchies, the pharmacological evidence base, and the high-stakes operative technicalities.
Quite. To achieve the necessary depth, we are dispensing with any casual format. We are stepping into the roles of a senior surgical examiner and an FRCS fellowship candidate sitting for their final exit viva. So to you, the listener, consider yourself sitting in the back of the examination hall.
Whether you are a junior surgical colleague prepping for your boards or a medical observer, just, well, pay close attention.
Because the pathology we are dissecting today does not offer the comfort of simple binaries like a clean bone fracture. We are navigating a diagnostic landscape that is the absolute definition of muddy waters.
It is intensely complex, yes.
So, candidate, take your seat. We will begin this viva by establishing the foundational physiology, because the assimilation of nutrients is not a singular event. It is a precarious, sequential cascade. I want you to detail the etiology and the applied anatomy of nutrient assimilation. Break down the physiological process into its three constituent phases, and do not spare the mechanistic details.
The systematic approach begins with the luminal phase, progresses into the mucosal phase, and ultimately resolves in the postabsorptive or transport phase. Failure at any single point in this continuum results in clinical malabsorption.
Let us start with the liminal phase now.
Right. The luminal phase is the preparatory stage. It relies on a coordinated combination of mechanical shear forces and chemical hydrolysis. Mastication and gastric churning emulsify the ingested matter into chyme. But the critical transition occurs as this chyme enters the duodenum.
The pH shift.
Exactly. The gastric acid must be neutralized by pancreatic bicarbonate to establish an optimal pH strictly around 6.5. This specific pH window is non-negotiable. It allows for the conformational activation of pancreatic enzymes.
Which enzymes specifically?
Specifically pancreatic lipase and its essential cofactor, colipase. These enzymes hydrolyze long-chain triglycerides into free fatty acids and monoglycerides. Simultaneously, conjugated bile acids, synthesized in the liver and secreted by the biliary tree, act as biological detergents.
They form the micelles.
Yes. They emulsify these newly free lipid droplets into water-soluble micelles. Without micelle formation, lipids absolutely cannot traverse the unstirred water layer that coats the intestinal lumen.
Let us pause on the liminal phase. Because, well, junior clinicians often view it as simple plumbing. You have described the healthy mechanism, but the interdependency is fragile.
It is incredibly fragile.
Think of it like washing heavily soiled, greasy dishes. You need mechanical scrubbing, you need the dish soap to act as the bile acids, and you need hot water. In this analogy, the pancreatic enzymes are the hot water. But consider a patient with Zollinger-Ellison syndrome harboring a gastronoma.
Ah, right, the massive gastric acid hypersecretion.
Exactly. That overwhelms the pancreatic bicarbonate buffer. The duodenal pH plummets well below that 6.5 threshold. The acidic environment irreversibly denatures the pancreatic lipase. You have perfectly intact plumbing, the liver is pumping out bile, but you have absolute chemical failure. The hot water has turned freezing cold, the grease congeals, and the clinical presentation is profound steatorrhea.
Which perfectly illustrates the luminal failure, yes.
Right. So let us advance to the mucosal phase. Where is the actual physiological uptick occurring?
Well, the uptake is dictated by surface area. The mucosal phase occurs at the brush border of the enterocytes, which demands an intact, highly folded microscopic architecture, the villi and their constituent microvilli. This is the factory floor of absorption.
And it is active, not passive.
Exactly. It is not merely a passive membrane. It is studded with active brush border enzymes. Disaccaridases like lactase, sucrase, and maltase are anchored right there, tasked with hydrolyzing the remaining carbohydrate oligomers into absorbable monosaccharides.
What about enteropeptidase?
Right. We also find enteropeptidase there, a critical enzyme that acts as a biological switch. It activates pancreatic trypsinogen into trypsin, which subsequently triggers the entire downstream cascade of protein digestion. Once the macromolecules are cleaved into their fundamental units, they are actively or passively transported across the apical lipid bilayer of the enterocyte.
But the journey does not end at the apical membrane. Once inside the enterocyte, the lipid fraction faces a massive logistical challenge compared to the highly soluble amino acids or simple sugars. Detail the final postabsorptive phase, specifically contrasting the vascular routing.
The postabsorptive phase is essentially a packaging and shipping operation. Amino acids and monosaccharides are relatively straightforward. They are water-soluble, so they exit the basolateral membrane of the enterocyte, diffuse directly into the mucosal capillary beds, and are routed straight to the liver via the portal vein.
For immediate hepatic processing.
Exactly. But the lipids require an entirely different infrastructure. The absorbed free fatty acids and monoglycerides are reesterified back into complex triglycerides within the enterocyte's smooth endoplasmic reticulum. The cell then bundles these triglycerides alongside cholesterol and coats them with specific apolipoproteins.
To form what?
To form massive spherical lipoprotein particles known as chylomicrons. Because of their sheer physical size, chylomicrons simply cannot cross the tight endothelial junctions of the mucosal blood capillaries.
So they go to the lymphatics.
Right. They must be exocytosed into the highly permeable lacteals that run up the central core of every single intestinal villus. From the lacteals, this milky, lipid-rich lymph is pumped through the mesenteric lymphatic channels to the cisterna chyli.
And then up the thorax.
Yes, up the entire length of the thorax via the thoracic duct, and is finally dumped directly into the systemic venous circulation at the junction of the left internal jugular and subclavian veins. It completely bypasses the first-pass metabolism of the liver.
A highly evolved, efficient system. But as surgeons, our livelihood is based on the catastrophic disruption of this anatomy. Let us define the anatomical parameters of short bowel syndrome. Differentiate between the embryological disasters we see in the pediatric ward and the acquired etiologies in the adult population.
Well, short bowel syndrome, or SBS, is clinically defined not just by length, but by physiological failure. It is a state where the remaining functional mass of the small intestine is insufficient to absorb the required fluid and nutrients to sustain life without artificial intravenous supplementation.
Give me the anatomical threshold.
Anatomically, the widely accepted threshold for SBS is having less than 200 centimeters of functioning small bowel remaining in continuity.
And the pediatric etiologies.
In the pediatric population, the etiology is predominantly congenital or developmental. We see intestinal atresias where segments of the bowel simply fail to canalize during embryogenesis. We also encounter catastrophic vascular events like midgut volvulus secondary to congenital malrotation.
Where the gut twists on its own pedicle.
Yes, cutting off its own blood supply and necessitating massive, life-saving resection of gangrenous bowel in a neonate.
And when we transition to the adult surgical wards, the pathology shifts from developmental errors to relentless acquired destruction.
Right. In adults, the leading drivers are acute ischemia and chronic inflammation. Acute superior mesenteric artery thrombosis or profound embolic events can infarct vast, continuous segments of the jejunum and ileum within hours.
Leaving the surgeon no choice but to perform a massive enterectomy.
Exactly. The other dominant adult etiology is Crohn's disease. Because Crohn's is characterized by transmural inflammation, fistulization, and dense fibrotic stricturing, these patients often face the operating table multiple times over decades. They undergo sequential resections, progressively whittling down their total intestinal length until they irrevocably cross that 200-centimeter threshold.
We have discussed the macroscopic loss of length, but we must also examine the pathophysiology of functional stagnation. Consider an adult patient with a surgically created blind loop, or perhaps dense fistulae from Crohn's. How does this altered anatomy breed small intestinal bacterial overgrowth?
Stagnation is the absolute enemy of a healthy intestinal microbiome. The small intestine is normally kept relatively sterile by the continuous sweeping action of the migrating motor complex. But blind loops and strictures create anatomical backwater.
Allowing colonic bacteria to ascend.
Exactly. They colonize and proliferate to massive concentrations within the jejunum and ileum. This is SIBO.
And more importantly, I want the exact molecular mechanism by which SIBO sabotages the luminal phase of fat absorption.
The sabotage is molecularly targeted. Earlier, we established that the liver conjugates bile acids with amino acids like glycine or taurine to make them amphipathic. The overpopulated colonic bacteria in SIBO secrete an enzyme called bile salt hydrolase,
which cleaves the conjugation.
Right, this enzyme rapidly deconjugates the bile acids.
To make this mechanism crystal clear for the listener, The bacteria are essentially destroying the physical utility of the bile. It was like trying to carry 20 heavy suitcases through an airport, but someone has snapped the handles off every single bag.
That is a perfect analogy. The luggage is still sitting there, the fat is still in the lumen, but you have lost the structural mechanism required to transport it across the barrier.
So what happens to those handleless bile acids?
Well, deconjugated bile acids are highly lipophilic. Without their amino acid handles, they are absorbed passively and prematurely in the very high proximal jejunum, rather than waiting for active transport in the terminal ileum.
Depleting the luminal pool.
Exactly. This rapid, inappropriate reabsorption completely depletes the luminal pool of bile salts. Without an adequate concentration, micelle formation ceases. The dietary triglycerides cannot be emulsified, lipase cannot access them efficiently, and the lipids are completely unabsorbable.
Resulting in steatorrhea and caloric wasting. Let us move from the bacterial to the immunological. We must exhaustively evaluate refractory celiac disease. Celiac disease is the bread and butter of medical gastroenterology, usually managed by dietary exclusion of gluten.
Right, a strict gluten-free diet.
But a deadly subset of patients progresses to refractory celiac disease, or RCD. Candidate, you must delineate the molecular mechanisms distinguishing RCD type 1 from RCD type 2. I want a strict focus on the immunophenotype of the intraepithelial lymphocytes.
The divergence between RCD1 and RCD2 represents a critical prognostic threshold. Clinically, RCD is defined as persistent symptoms of malabsorption, accompanied by persistent villus atrophy, despite strict verified adherence to a gluten-free diet for at least 12 months.
Assuming hidden gluten exposure has been meticulously ruled out.
Yes, absolutely. The distinction between the types lies entirely in the tissue architecture and the nature of the intraepithelial lymphocytes, or IELs. In RCD1, the molecular pathology is essentially indistinguishable from conventional active celiac disease. The IEL population is expanded, but crucially, it is a polyclonal expansion.
Meaning they retain a normal immunophenotype.
Right. They express the surface CD3 receptor, they express cytoplasmic CD3, and they maintain the CD8 coreceptor. Genetic analysis of their T-cell receptor genes reveals a normal, diverse, polyclonal rearrangement pattern. It is an ongoing, damaging, inflammatory response, but it is fundamentally benign.
And RCD2. The listener needs to understand that this is where the pathology steps out of the realm of benign inflammation and takes a sinister pre-malignant turn.
RCD2 is characterized by an aberrant clonal expansion of IELs. These cells have mutated and lost their mature identity. They characteristically lack the surface CD3 receptor. They are surface CD3 negative.
Although they paradoxically retain cytoplasmic CD3.
Exactly. And they also lose the CD8 coreceptor. When hematopathologist performs a PCR analysis on this tissue, they do not see a diverse immune response. Instead, they find a heavily driven monoclonal rearrangement of the T-cell receptor beta or gamma genes.
Confirming a rogue clone.
Yes. This molecular signature confirms that a single mutated T-cell clone has escaped regulatory control and begun to proliferate autonomously within the gut epithelium.
I am going to push back on this progression because this is where the surgical danger materializes. We have defined an aberrant clonal population of T cells. I demand you explain the why behind the resultant tissue destruction. How does a localized cluster of mutated lymphocytes instigate catastrophic mucosal inflammation that progresses to ulcerative jejunolitis?
Well, the aberrant clonal T cells in RCD2 are not benign passengers. They are deeply dysregulated and intensely cytotoxic. Because they have lost normal regulatory receptors, they upregulate and overexpress activating natural killer receptors.
Specifically, markers like NKp46.
Right, exactly, NKp46. In a normal immune response, T cells require specific antigen presentation to become aggressive. These RCD2 clones do not. Even in the complete absence of dietary gluten, these clonal IELs exist in a state of autonomous hyperactivation.
Attacking healthy tissue.
Yes, they mount a massive, localized, unprovoked cytotoxic attack directly against the adjacent, healthy intestinal epithelial cells. They force unrelenting apoptosis of the enterocytes. The rate of destruction vastly outpaces the regenerative capacity of the crypt stem cells, stripping the mucosa completely bare.
Forming deep ulcerations.
Exactly. Coalescing ulcerations throughout the jejunum and ileum. And because the inflammatory cascade is so intensely concentrated, these ulcers do not remain superficial. They burrow aggressively down through the submucosa, eroding directly into the muscularis propria.
Which sets the stage for transmural perforation or massive uncontrollable gastrointestinal hemorrhage. The biology literally eats the structural integrity of the bowel wall. Now, let us test your physiological reasoning with this speculative scenario. We have just dissected immune-mediated villus atrophy. I want you to predict the anatomical consequences of radiation enteritis on mucosal cellular turnover. A patient receives high-dose pelvic radiotherapy for a gynecological malignancy. Focus your answer precisely on the crypts of Lieberkühn.
Radiation enteritis forces mucosal failure through an entirely different physical mechanism. The intestinal epithelium is one of the most rapidly dividing tissues in the human body. Enterocytes only live for a few days before sloughing off the villus tips.
Driven by the stem cells.
Right. This massive turnover is driven exclusively by the pluripotent stem cells sequestered at the protected base of the crypts of Lieberkühn. Ionizing radiation inflicts double-strand DNA breaks.
So the mature enterocytes survive the initial blast.
Yes, because they are non-dividing and relatively radioresistant. However, the rapidly dividing stem cells in the crypts are exquisitely radiosensitive. The radiation shatters their DNA, halting mitosis and triggering widespread stem cell apoptosis.
Creating a supply chain collapse.
Precisely. The mature enterocytes continue to slow off the villus tips at their normal rate, but because the crypt stem cells are dead, there is no replacement generation rising up to replace them. Over a span of mere days, the villi become progressively blunted, denuded, and structurally collapse.
And chronically.
If the radiation insult is chronic, the acute mucosal collapse progresses to obliterative endarteritis in the submucosa, leading to deep tissue ischemia, transmural fibrosis, and a permanently scarred, highly strictured segment of bowel.
A sound mechanical analysis. We will now advance our review to the diagnostic hierarchy. As senior clinicians, the temptation is always to order a shotgun blast of modern cross-sectional imaging and genetic panels. But we must ground ourselves in the patient in front of us. Conduct a systematic review of the clinical presentations of malabsorption. Do not just list symptoms. Explain the physiological deficit driving them.
Well, the clinical presentation reflects a systemic starvation in the midst of plenty. The absolute hallmark gastrointestinal symptom is steatorrhea. Patients describe the passage of pale, incredibly bulky, foul-smelling stools that are difficult to flush and often float, covered in a greasy sheen.
Indicating the failure to assimilate dietary fat.
Exactly. Accompanying this is severe weight loss despite ravenous caloric intake, coupled with progressive muscle wasting as the body cannibalizes its own protein stores. We frequently observe profound peripheral edema and ascites, which is the oncotic result of hypoproteinemia.
Driven by either amino acid malabsorption or a protein-losing enteropathy. But the diagnosis is often sealed by the extraintestinal manifestations, specifically those tracking the loss of the fat-soluble vitamins, A, D, E, and K. Detail these for me.
When biliary micelles fail to form, these vitamins are lost in the stool. Vitamin A malabsorption presents ophthalmologically as nyctalopia or night blindness due to the failure of the retina to synthesize rhodopsin.
And the presentation of vitamin K2 malabsorption. This is a highly sophisticated physiological consequence. The listener needs to grasp the irony of this specific deficiency, as it is something many junior clinicians completely overlook on a metabolic panel.
The vitamin K2 paradox is a striking example of metabolic uncoupling. We all know severe vitamin K malabsorption causes hypoprothrombinemia, leading to bleeding diatheses. But vitamin K2 specifically acts as the essential cofactor for the carboxylation of two critical bone and vascular proteins, osteocalcin and matrix glycoprotein.
Break those down.
Right. Osteocalcin directs serum calcium into the bone matrix. Matrix glycoprotein acts as a scavenger, actively preventing calcium from depositing in the intimal lining of blood vessels. Therefore, prolonged K2 deficiency produces a profoundly ironic phenotype.
The calcium cannot get into the bones where it belongs.
Exactly, resulting in severe osteomalacia and osteoporosis. While simultaneously, the calcium precipitates out into the vasculature where it shouldn't be, causing extensive premature vascular calcification.
Hollow bones and rock-hard arteries. What about vitamin E?
As our primary lipid-soluble antioxidant, its loss leaves neural tissue vulnerable to oxidative damage. This manifests neurologically as peripheral neuropathy, profound spinocerebellar ataxia, and hemolytic anemia due to red blood cell membrane fragility.
Let us move to the physical exam. What are you looking for on the skin and mucosa?
On the integumentary system, we look for dermatitis herpetiformis. It's an intensely pruritic, blistering, vesicular rash classically distributed on the extensor surfaces of the elbows and knees. It is pathognomonic for celiac disease, driven by IgA deposition in the dermal papillae. We must also look for glycitis.
A beefy red, inflamed tongue.
Yes, indicating severe B12 or folate deficiencies and angular stomatitis fissuring at the corners of the mouth from iron or riboflavin loss.
Having established the clinical phenotype of catastrophic nutrient failure, we turn to the laboratory investigations. We demand high sensitivity and specificity. Detail the 72-hour fecal fat test. The textbooks call it the gold standard, yet anyone who has worked on a surgical ward knows it is fraught with logistical nightmares. Analyze its parameters.
The 72-hour quantitative fecal fat test remains the undisputed physiological gold standard for diagnosing both the presence and the absolute severity of fat malabsorption. However, the execution is highly demanding. The strict protocol requires the patient to consume a carefully standardized high-fat diet.
Exactly 100 grams of fat per day.
Yes, for 3 consecutive days. During this entire 72-hour window, absolutely all stool output is collected in specialized containers. This pooled specimen is then homogenized in the laboratory, and the lipid content is chemically extracted, usually via the Van de Kamer titration method, and quantified.
Give me the reference ranges.
Normal excretion is strictly less than 7 grams of fat per day, proving the healthy gut absorbs over 93% of the ingested lipid load. An excretion rate of 7 to 14 grams per day indicates a mild to moderate malabsorptive state. Excretion exceeding 14 grams per day confirms severe, life-threatening malabsorption.
In severe pancreatic failure, that can easily exceed 40 grams. But you must acknowledge the fundamental limitation of this test regarding diagnostic specificity. It tells you a disaster is happening, but it refuses to tell you where.
Precisely. It is a purely quantitative measure. It is entirely blind to the anatomical origin or the chemical nature of the defect. It confirms fat is being wasted into the toilet, but it cannot differentiate whether the failure is luminal due to pancreatic insufficiency, mucosal due to celiac disease, or postabsorptive.
Therefore, we deploy secondary diagnostics to isolate the geography of the failure, differentiate the utility of fecal elastase 1 and the various breath tests.
To interrogate the luminal phase and specifically isolate the pancreas, we measure fecal elastase 1. Elastase 1 is a highly specific pancreatic proteolytic enzyme that is uniquely resistant to bacterial degradation during its transit through the colon. We only need a single random spot stool sample.
And the cutoff.
A concentration of less than 200 micrograms of elastase per gram of stool firmly confirms pancreatic exocrine insufficiency. If the elastase is normal, the defect lies elsewhere.
And for non-pancreatic luminal defects, or mucosal carbohydrate defects.
We utilize breath tests. These tests elegantly measure the specific gaseous byproducts produced by the enteric microbiome's metabolism of ingested substrates. Human cellular metabolism does not produce hydrogen or methane gas. Only the fermentation pathways of enteric bacteria do.
So the patient ingests a carbohydrate load, like 50 grams of lactose.
Right. And if we detect an abnormal spike in their exhaled breath hydrogen using a strict clinical cutoff of an increase greater than 20 parts per million over baseline, or a spike in methane greater than 10 parts per million, it proves the carbohydrate was not absorbed by the mucosa and was instead fermented by bacteria.
How specific is this for lactose malabsorption?
The specific breath test boasts a 77.5% sensitivity and an impressive 97.6% specificity. Crucially, the timing of the gas spike is diagnostic. If the hydrogen spike occurs very early in the test, within the first 60 to 90 minutes, it suggests SIBO.
Because the bacteria are inappropriately colonizing the proximal small intestine.
Yes, fermenting the substrate immediately, long before it ever reaches the colon.
Now, let us drag the focus back to the diagnosis of refractory celiac disease. You have identified the clinical signs, you have quantified the malabsorption, but to diagnose RCD, we require tissue. The listener must understand that diagnosing RCD is not merely a matter of taking a single pinch biopsy and tossing it into a pot of formalin. Detail the exact endoscopic biopsy protocol required to capture these aberrant clones.
The tissue acquisition protocol for suspected RCD must be exhaustive and methodologically flawless. Standard celiac screening biopsies are entirely insufficient. The endoscopist must obtain a broad geographical sample of the duodenum to account for patchy disease.
How many biopsies?
At least 1 to 2 targeted biopsies from the duodenal bulb, and a minimum of 4 distinct biopsies from the distal duodenum to accurately grade the baseline villus architecture using the Marsh classification. But the critical deviation occurs when RCD2 is suspected. The endoscopist must take an additional 6 biopsies specifically dedicated for flow cytometry and immunohistochemistry.
And how are these handled? Because this is where mistakes are made.
Right. These specific tissue samples must absolutely not be placed in standard formalin. Formalin chemically cross-links proteins, permanently fixing the tissue and completely destroying the delicate three-dimensional cell surface receptors necessary for flow cytometry.
So what medium do you use?
These crucial biopsies must be immediately immersed in fresh, unfixed RPMI cell culture medium or sterile normal saline and rushed to the laboratory. This specialized handling allows the hematopathologist to perform real-time live cell flow cytometry.
To detect the exact ratio of the aberrant surface CD3 negative intraepithelial lymphocytes.
Exactly. And it preserves the nucleic acids required to run the PCR that will detect the monoclonal T-cell receptor gene rearrangements, the definitive molecular fingerprint of RCD2.
I am mandating a rigorous critique of our radiological staging here. When RCD2 is confirmed, the clinical anxiety surrounding its progression to enteropathy-associated T-cell lymphoma, or EATL, is suffocating. The knee-jerk instinct of the medical oncologist is to immediately order a full-body 18F-FDG-PTCT. Analyze the diagnostic accuracy of this modality.
Well, the PTCT utilizes a radio-labeled glucose analog to map areas of highly accelerated metabolic activity across the body. In the specific context of staging RCD2, it possesses an undeniably high sensitivity for detecting hypometabolic lymphomatous transformation. If an established EATL mass is growing, the PT scan will almost certainly light up with intense focal avidity.
But I want you to carefully detail the massive diagnostic pitfalls of a PET scan in this specific, highly inflamed patient population.
The clinical trap lies in its specificity, which is dreadfully compromised in the setting of severe chronic enteropathy. The pitfall is the staggering false positive rate. RCD2 is, by its very definition, a state of profound destructive intestinal inflammation.
The host immune system is responding to the ulcers.
Right. They flood these benign inflammatory ulcers with macrophages, neutrophils, and reactive lymphocytes. These benign inflammatory cells are also highly metabolically active. They will avidly uptake the 18F-FDG tracer, creating a bright signal on the scan that perfectly mimics a malignant lymphoma.
Now what about the thymus?
Yes. The chronic malnutrition and extreme immune dysregulation inherent to these patients frequently lead to incidental thymic hyperplasia. The thymus gland enlarges and becomes metabolically hyperactive, which will present on the PT scan as a terrifying false positive hypermetabolic mass in the anterior mediastinum.
Therefore, interpreting a positive PTCT in an RCD2 patient requires extreme caution. A hypermetabolic focus is merely suggestive. It absolutely mandates targeted surgical excision, laparoscopy, or deep push enteroscopic biopsy for definitive histological confirmation before any clinician can ethically declare the patient has EATL and initiate systemic chemotherapy.
Absolutely.
Now, I must press you on the clinical utility of some legacy tests. When I was a junior registrar, we spent hours torturing patients with the D-xylose absorption test and the Schilling test, yet you have deliberately omitted them from your modern diagnostic hierarchy. Explain to the listener why these tests belong in a museum.
Well, the D-xylose test and the Schilling test are historically significant, but they are practically obsolete. D-xylose is a simple 5-carbon monosaccharide. It is absorbed directly across an intact intestinal mucosa without requiring any preliminary digestion by pancreatic enzymes or bile.
So, historically, the patient ingested a 25-gram dose.
Right, and we measured their 5-hour urinary excretion. If excretion was low, it indicated a structural mucosal defect like celiac disease, neatly distinguishing it from pancreatic insufficiency. However, the test is plagued by confounding variables: delayed gastric emptying, subclinical renal insufficiency, massive bacterial overgrowth, all drastically skew the results.
Making it highly unreliable compared to direct endoscopic visualization.
And the Schilling test.
The Schilling test was an elegant, multi-stage physiological puzzle utilized to determine the cause of vitamin B12 malabsorption. It utilized orally ingested, radio-labeled vitamin B12 alongside injections of intrinsic factor and a massive intramuscular flushing dose of non-radioactive B12.
And why have we abandoned it? Several reasons. The immense regulatory and safety complexities of handling radioactive isotopes, the cessation of commercial availability of the substrates, and the sheer logistical nightmare of requiring a flawless 24-hour urine collection from the patient, which suffers from notoriously terrible compliance.
What have we replaced them with?
Today, we've replaced these multi-day hurdles with highly specific rapid serology. We can directly measure anti-tissue transglutaminase IgA and anti-deamidated gliadin peptide antibodies from a simple blood draw to screen for celiac disease with immense accuracy, and we utilize HLA, DQ2, and DQ8 genetic testing.
Vastly cheaper, zero radiation, and fundamentally more accurate. That concludes our diagnostic review. Let us transition to the evidence base. Diagnosis without an evidence-based intervention is merely academic observation, and we must manage these complex patients. Detail the core tenets of the landmark guidelines, specifically the AGA Clinical Practice Update on RCD and the Joint UEG and ESPEN Consensus.
The AGA Clinical Practice Update serves as the definitive, evidence-based algorithm for navigating RCD. Its absolute core tenet is the strict, uncompromising clinical differentiation between RCD1 and RCD2. The guidelines emphasize that their pharmacological management pathways diverge drastically at this juncture.
And prior to initiating toxic immunosuppression.
The AGA mandates that the clinician must absolutely rule out ongoing inadvertent gluten exposure. The guidelines highlight the utility of emerging objective biomarkers, such as detecting gluten immunogenic peptides directly in the patient's stool or urine,
Proving definitively whether gluten is still traversing their gut, and the UEG and ESPN guidelines.
They focus heavily on mitigating the metabolic catastrophe of malabsorption. Their core tenet is aggressive, proactive nutritional support. They emphasize the early initiation of individualized parenteral nutrition the moment enteral absorption fails. Crucially, they explicitly note in their data that severe hypoalbuminemia is not merely a marker of malnutrition, but a powerful, independent predictor of overall mortality.
Let us break down the pharmacological standards of care. Walk me through the first-line and second-line therapies, citing the specific trial data. Start with the steroids. Explain the exact administration technique because the mechanism of delivery here is just as important as the drug itself.
The first-line pharmacological standard of care for inducing remission in both RCD1 and RCD2 is targeted gut-directed corticosteroid therapy. The evidence-backed agent of choice is open-capsule budesonide. Budesonide is chosen because it possesses massive topical anti-inflammatory potency, but undergoes extremely rapid first-pass hepatic metabolism.
Minimizing systemic side effects.
Exactly. However, standard enteric-coated budesonide pills are designed to release in the terminal ileum and colon for Crohn's disease, which is useless for proximal celiac lesions. Therefore, the precise off-label administration technique is critical. The patient is instructed to physically break open the 3 mg budesonide capsule.
And mix it into an acidic vehicle.
Right, classically applesauce, and consume it. The acidic environment prevents premature dissolution in the stomach, allowing the granules to wash directly over the inflamed duodenal and jejunal mucosa, providing massive, direct, topical immunosuppression.
Give me the regimen and the trial data.
The regimen is typically 3 mg 3 times daily. The clinical trial data supporting this shows a 92% clinical response rate in arresting symptoms and an 89% histologic improvement rate, actively reversing the mucosal architecture damage. If it fails, systemic oral prednisone at 40 to 60 mg daily is the harsh alternative, though it carries a severely high burden of systemic toxicity.
And when the applesauce trick fails, when we are staring down the barrel of RCD2, and flow cytometry confirms the monoclonal T-cell population is expanding despite topical steroids. Detail the second line, chemotherapeutic options.
When RCD2 becomes steroid refractory, we escalate to systemic chemotherapy. The most established evidence-based agent in this setting is cladribine. Cladribine is a synthetic purine analog that specifically targets and induces apoptosis in rapidly dividing lymphocytes,
Aiming to eradicate the rogue T-cell clones.
Yes. It is typically administered via continuous intravenous infusion at 0.1 mg per kilogram per day. The efficacy data is sobering. Among the highly selected subset of patients who actually respond to induction, the 5-year overall survival rate is approximately 63%.
But highlight the severe caveat of this therapy.
The long-term data clearly shows it does not entirely eliminate the underlying malignant potential. The persistent, insidious risk of those surviving clonal cells undergoing full malignant transformation into EATL remains exceptionally high. It buys time, it rarely buys a permanent cure.
Are there salvage therapies?
For a robust cohort facing imminent mortality, autologous hematopoietic stem cell transplantation is utilized. High-dose conditioning chemotherapy vaporizes the intestinal immune system, followed by rescue with an infusion of their own pre-harvested stem cells. It's deeply morbid, but yields up to an 85% clinical response rate and a 66% 4-year survival rate.
Shifted to short bowel syndrome, how has the evidence base shifted?
It has fundamentally shifted away from purely managing TPN complications toward active intestinal rehabilitation. Teduglutide, a recombinant glucagon-like peptide 2 analog, is now standard of care. Daily subcutaneous injections of teduglutide promote massive structural mucosal hypertrophy.
maximizing the remaining absorptive surface area.
Exactly, significantly reducing the patient's daily volumetric reliance on total parenteral nutrition.
I'm going to interject here, and I want you to listen carefully to the premise of my challenge. We're discussing the management of RCD1. There's a very strong temptation among medical gastroenterologists to quickly escalate a patient from topical steroids directly to targeted systemic immunosuppressants, specifically purine analogs like azathioprine or mercaptopurine.
As a steroid-sparing agent to maintain long-term remission in RCD1.
Yes. As a surgeon who is forced to operate on the malignant endpoints of these diseases, I view this practice with extreme, almost visceral trepidation. I want you to explain why. How must the introduction of these purine analogs be weighed against the underlying biology? You are suppressing inflammation, yes, but you are actively crippling their tumor surveillance.
Your trepidation is entirely justified. The use of azathioprine in RCD1 is a high-wire act. The agents are undeniably effective for their primary indication. Data shows an approximately 71% clinical response rate in maintaining durable remission for RCD1 patients by blunting the rampant proliferation of polyclonal T cells.
But the biological trade-off is massive.
Exactly. We must constantly recall that chronic celiac disease and RCD inherently possess a deeply deranged intestinal immune environment that is already highly predisposed to lymphoma. By introducing a blanket, untargeted immunosuppressant like azathioprine, we are intentionally crippling the patient's intrinsic immune surveillance.
So if a single aberrant clone begins to develop?
The azathioprine has already suppressed the healthy cytotoxic T cells and natural killer cells that would have otherwise eradicated that single mutated clone. Thus, it opens the biological door for accelerated, unchecked lymphomagenesis. The evidence dictating their use is brutally clear. First, they must never be utilized in confirmed RCD2.
Where the malignant clone already exists and requires destruction.
Right. And second, their use in RCD1 must be strictly accompanied by aggressive, continuous endoscopic and molecular surveillance for lymphoma.
That is the exact synthesis I require. We now cross the blood-brain barrier of this viva, stepping directly into the operating theater. Let us discuss operative technicalities. To the listener observing this exchange, this is where academic theory meets cold steel. Detail the indications for surgical intervention in this cohort.
In the context of RCD2, surgical intervention is almost universally driven by sudden, catastrophic mechanical failures. The primary indications demanding emergency laparotomy are acute free bowel perforation, presenting with rigid peritonitis, acute mechanical bowel obstruction caused by a bulky lymphomatous mass or fibrotic strictures, and finally, localized massive gastrointestinal hemorrhage arising from deeply eroded mesenteric vessels.
We will now simulate the gold standard operation. You are the consultant on call. You're performing an emergency laparotomy on a 55-year-old patient with known RCD2. They are profoundly hypoalbuminemic. They have developed a high-grade mechanical obstruction secondary to an ETL mass in the mid-jejunum. Walk me step by step through this laparotomy. I want the strict principles of oncologic small bowel resection.
The patient is prepped for a full, wide midline laparotomy, extending from the xiphoid to the pubis. Upon entering the abdomen, my first priority is a systemic exploration. I meticulously run the entire length of the small bowel from the ligament of Treitz down to the ileocecal valve to visually and tactilely locate the primary mass and assess for any synchronous multifocal lymphomatous deposits.
Having isolated the mass, the operative principle shifts to strict oncologic clearance.
Right. I must achieve wide, macroscopically negative margins. I will resect at least 5 to 10 centimeters of grossly healthy bowel, both proximal and distal to the tumor. Crucially, the management of the mesentery dictates the accuracy of the staging. I cannot simply hug the bowel wall.
What must you do?
I must perform a high, deep, V-shaped excision of the associated mesentery, taking the dissection planes all the way down to the mesenteric root. I must achieve high double ligation of the specific mesenteric branches supplying that segment. This wide harvest captures the entire regional draining lymphatic basin, providing the pathologist with an adequate nodal yield.
Once the en bloc resection is complete and the specimen is off the table, the critical life-altering decision is reconstruction. You specified, this patient is profoundly hypoalbuminemic. Give me your physiological rationale for the reconstruction phase.
Well, serum albumin is a critical surrogate marker for global tissue healing capacity. In a patient with an albumin level hovering around 1.8 grams per deciliter, the bowel tissue is inherently edematous, friable, and entirely lacks the protein synthesis capabilities to generate fibroblasts required to heal a surgical suture line.
Therefore, attempting to perform a primary end-to-end anastomosis is contraindicated.
Absolutely contraindicated. The risk of a lethal anastomotic leak is unacceptably high. I would instead elect for damage control. I would bring the healthy proximal bowel end out through the abdominal wall, maturing it as an end-jejunostomy stoma. I would either bring the distal limb out as a mucus fistula or staple it off securely as a Hartmann's pouch.
Prioritizing immediate survival and source control over anatomical continuity.
Yes, we can reverse the stoma months later, only after the lymphoma is treated and their nutritional status is fully optimized via TPN.
A highly safe, decisive surgical plan. But the abdomen is a master of intraoperative surprises. You cannot rely on the preoperative scan. Suppose you open the peritoneum expecting that solitary ETL mass, but you discover miliary white lymphomatous seeding scattered throughout the entire peritoneum. How does your overarching operative strategy pivot?
This surprise requires an immediate recalibration of the objective. If I discover diffuse miliary seeding, the disease is stage 5E, widely metastatic, and incurable by surgical excision. Proceeding with a massive high morbidity resection will not alter survival, but will inflict trauma that prevents palliative chemotherapy.
So the goal shifts to palliation.
Exactly. I would perform the absolute minimal surgical procedure to relieve the acute obstruction, perhaps a simple side-to-side palliative bypass around the mass. Concurrently, I take generous representative biopsies of the peritoneal nodules for definitive tissue diagnosis.
Or, consider the converse scenario. You open the abdomen and find thick, creeping mesenteric fat wrapping around the bowel, and distinct skip lesions of inflammation. It is severe, undiagnosed, penetrating Crohn's disease. How does your strategy pivot now?
The paradigm flips completely to aggressive bowel conservation. Crohn's is relentlessly recurring. Every centimeter is precious. I would immediately abandon the wide oncologic mesenteric harvest. If the obstructed segments are short, fibrotic strictures, I perform multiple strictureplasties to widen the lumen without sacrificing length.
Excellent adaptability. Let us stress test your physiological judgment with some extreme clinical scenarios. First, the pregnant patient. A 28-year-old female, second trimester. She has an acute free bowel perforation from severe ulcerative jejunitis. Discuss the physical positioning, choice of anesthesia, and fetal monitoring required to keep two vastly different patients alive simultaneously.
Operating on a pregnant patient in the second trimester introduces profound complexities. Physical positioning is paramount. The gravid uterus is heavy. If the patient is placed flat and supine, the uterus physically compresses the inferior vena cava against the spine,
Which abruptly reduces venous return.
devastating maternal cardiac output, leading to severe placental hypoperfusion and fatal fetal hypoxia. Therefore, before induction, she must be placed in a strict left lateral decubitus, tilt-angled at least 15 to 30 degrees, utilizing a wedge under her right hip to displace the uterus off the IBC.
And the anesthesia.
We utilize rapid-sequence general endotracheal anesthesia to protect her airway due to delayed gastric emptying. But the critical mandate is to strictly avoid maternal hypotension, hypoxia, and acidosis. The placental circulation entirely lacks intrinsic autoregulation. It is completely dependent on maternal blood pressure.
The anesthetist must use vasopressors judiciously.
Yes, specifically alpha agonists like phenylephrine. Finally, continuous sterile transabdominal fetal heart rate monitoring is mandatory with an obstetrician present in the theater. This provides real-time telemetry to detect early signs of fetal distress, like late decelerations.
A comprehensive grasp of maternal fetal physiology. Now consider the auto-anticoagulated patient, a patient with long-standing fat malabsorption and profound, uncorrected vitamin K deficiency. You encounter massive, diffuse, non-pulsatile intraoperative hemorrhage. The entire surgical field is weeping blood. How do you surgically and medically navigate this disaster?
Standard surgical hemostasis techniques like monopolar cautery or clips will completely fail because there is no single bleeding vessel to target. The patient entirely lacks the functional carboxylated vitamin K-dependent clotting factors, 2, 7, IX, and X.
So what is your immediate physical action?
I rapidly pack the entire abdomen tightly with dry laparotomy sponges to provide overwhelming mechanical tamponade. I step back, maintain pressure, and clearly communicate the crisis to the anesthetist. We must immediately initiate massive transfusion protocols, but specifically replace the missing factors.
With 4-factor prothrombin complex concentrate.
Right, PCC provides immediate, highly concentrated functional doses of those deficient factors, reversing the coagulopathy within minutes. We simultaneously administer high-dose intravenous vitamin K, but I know that takes 6 to 12 hours to become active. I will not touch the surgical field again until the biochemical coagulopathy is definitively reversed by the PCC.
I'm going to stop you mid-operation for one final technical pushback. As you are resecting this EATL mass, you must protect the patient from iatrogenic short bowel syndrome. How do you precisely calculate the remaining bowel length and assess the vascular supply before committing to the irreversible transaction of the stapler?
Prevention of iatrogenic SBS requires meticulous physical measurement. I use a sterile umbilical tape, measuring along the antimesenteric border. I measure from the ligament of Treitz down to my proposed proximal margin, and from the ileocecal valve up to my distal margin. I must mathematically confirm the sum exceeds 200 centimeters.
And the vascular supply.
Visual inspection of the serosa is dangerously insufficient. The deep mesenteric wedge can inadvertently sacrifice vital collateral vascular arcades. Before dividing the main vessels, I apply atraumatic bulldog clamps to the targeted arteries and veins and meticulously observe the perfusion of the retained bowel ends.
And if there is doubt?
I utilize intraoperative fluorescent angiography. I have the anesthetist inject indocyanine green intravenously. Within seconds, I use a near-infrared laparoscope to visually confirm brilliant, robust microvascular perfusion. Only then do I fire the stapler.
Exceptional. We will now move to complications and prognosis. The operation is over. Detail the postoperative management, focusing on the risk of an anastomotic leak in these malnourished states. How do we objectively grade a major leak using the Cladian-Dindo classification?
In a profoundly hypoalbuminemic patient, collagen synthesis is fundamentally crippled. We must monitor them obsessively for the subtle heralds of a leak. An unexplained tachycardia, a low-grade fever, or turbid fluid in the drains.
If a leak occurs, requiring an emergency relaparotomy to wash out the abdomen and form a stoma.
Under the Cladian-Dindo system, because it requires surgical intervention under general anesthesia, it is classified as a grade lead complication. If the ensuing sepsis causes profound hypotension and single-organ dysfunction requiring ICU admission and vasopressors, it escalates to a grade IVA complication.
And as we attempt to reverse their malnutrition, we risk triggering refeeding syndrome. What exact biochemical cascade are we watching for?
Refeeding syndrome is a fatal shift in intracellular fluids and electrolytes. A chronically malnourished patient is severely depleted in phosphorus, potassium, and magnesium. When we suddenly reintroduce a massive carbohydrate load, it triggers a massive surge of endogenous insulin.
Which drives glucose and those electrolytes into the cells.
Exactly. Plunging the patient into severe hypophosphatemia, causing respiratory muscle weakness, severe hypokalemia, triggering lethal ventricular arrhythmias, and hypomagnesemia, causing seizures. We mitigate this by reintroducing nutrition incredibly slowly and aggressively supplementing electrolytes intravenously beforehand.
Assuming the patient survives, we must establish long-term surveillance protocols for patients surviving RCD2 and EATL. What modalities are we utilizing?
We primarily utilize video capsule endoscopy to visually inspect the small bowel mucosa for early recurrence of ulcerative lesions, avoiding the radiation burden of CT scans. We alternate this with magnetic resonance enterography to assess transmural architecture. For micronutrient deficiencies, we mandate regular DXA scans to quantify bone mineral density, as vitamin D and K2 loss leads to accelerated osteoporosis.
State the overarching prognosis for RCD2.
The prognosis is undeniably poor. RCD2 carries an exceptionally high rate of progression to EATL. Even with aggressive modern chemotherapy, the 5-year overall survival rate is frequently cited as less than 50%.
I am going to push back on the post-resection patient. The patient survives the laparotomy but has a high-output NJ-genostomy stoma. I demand the exact pharmacological and dietary parameters for managing this high output and your algorithm for weaning them off TPN.
Managing a high-output stoma requires strict oral fluid restriction. We limit hypotonic fluids like plain water to less than 500 milliliters a day because drinking plain water paradoxically increases sodium secretion into the lumen. Instead, we mandate an isotonic leukosaline oral rehydration solution with exactly 90 millimoles of sodium per liter.
Pharmacologically,
We deploy aggressive antimotility agents, high-dose loperamide up to 16 milligrams 4 times daily, physically crushed before administration. We layer this with codeine phosphate and high-dose proton pump inhibitors to reduce gastric acid hypersecretion.
And weaning the TPN.
We strictly monitor daily urine output, aiming for greater than 1 liter per day, with a urinary sodium greater than 20 millimoles per liter. This proves they are absorbing sufficient fluid. We incrementally decrease TPN while maximizing GLP-2 analogs like teduglutide.
Candidate, we have arrived at the final viva. We're shifting gears into rapid-fire, high-pressure execution. These are killer questions from previous FRCS exit papers. Killer question 1. A 45-year-old patient who is known to be HIV positive, with a CD4 count of less than 200, suffers from chronic malabsorption. They present in profound septic shock. Imaging reveals a perforated small bowel secondary to a newly diagnosed massive EATL. You have them in theater. Do you proceed with a massive oncologic resection or a minimal damage control surgery?
This patient is an absolute extremist, battling advanced AIDS, systemic sepsis, and aggressive malignancy. Their physiological reserve is 0. Attempting a multi-hour oncologic resection will kill them on the table. I unequivocally elect for damage control surgery. My priority is to stop the gross bacterial contamination.
So what exactly are you doing?
I will aggressively staple off the bowel, proximal and distal to the perforation, resecting the leaking segment with absolutely minimal margins. I will not attempt an anastomosis nor a stoma. I leave the stapled ends in discontinuity. Because their CD4 count is so low, I copiously wash out the abdomen and leave it completely open, applying a negative pressure wound therapy system.
I'm going to interrupt you there. The family is out in the waiting room. They know it's cancer. They're demanding a cure.
Yeah.
They want the tumor out today, and you are telling me you are going to leave him chopped open in the ICU with cancer still inside his abdomen. Defend that clinical judgment to me right now.
I will defend it with the brutal reality of the physiology. I cannot cure cancer in a patient who has bled to death or died of refractory septic shock on my operating table. My job as a surgeon is not to soothe anxiety with a Pyrrhic victory. My job is to keep the patient alive. If I attempt an oncologic resection, he dies today. If I perform damage control, he might survive the night.
Decisive and correct. You must survive the night to fight the cancer tomorrow. Killer question 2. An 80-year-old, highly comorbid patient with established short bowel syndrome develops recurrent, life-threatening, catheter-related bloodstream infections from their TPN central line. Discuss the ethical framework of withdrawing life-sustaining nutritional support versus utilizing extreme anatomical lengthening procedures, such as the STEP procedure.
This scenario places us on the boundary between non-maleficence and patient autonomy. Recurrent infections in an 80-year-old carry a massive mortality risk. However, ceasing TPN is the functional equivalent of withdrawing life-sustaining therapy. It will predictably lead to death by starvation.
So what is the surgical option?
The serial transverse enteroplasty, or STEP procedure, is an anatomical manipulation involving sequentially firing staplers across the bowel in a zigzag pattern to artificially lengthen the lumen. However, performing this multi-hour, deeply morbid operation on an 80-year-old comorbid patient battling systemic sepsis is surgically irresponsible. The risk-to-benefit ratio is prohibitively skewed toward operative mortality.
So you would advise against it?
Vehemently. I would focus entirely on aggressive central line salvage or transitioning gracefully to palliative goals of care if venous access is exhausted.
Candidate, you have navigated the muddy waters with precision and sound clinical judgment. You may step down. That concludes the formal viva. To you, the listener, who has sat in the back of the hall with us through this exhaustive evaluation, we have spent the last hour dissecting the precise mechanics of how the bowel breaks down and how we surgically attempt to patch the leaks. But I want to leave you with a final, highly advanced concept that we have only just begun to touch upon in the surgical literature. I ask you to ponder this as you close your textbooks tonight. Will the ultimate surgical cure for malabsorption and short bowel syndrome soon shift away from these crude, mechanical lengthening procedures? Consider the imminent reality of transplanting bioengineered intestinal organoids. Imagine a future where we cultivate healthy, functioning metal tissue in a laboratory from the patient's own harvested pluripotent stem cells. We graft this tissue onto a decellularized biological scaffold, and we implant it back into the abdomen. If we can successfully regenerate the functional crypts of Leberkuhn, eliminating the need for TPN entirely, we will forever alter the landscape of gastrointestinal surgery. We will move from being carpenters who cut and patch to biological architects who rebuild. Think on that profound shift as you review your notes. Until the next deep dive.